ओके ओके। तो अगर भगवान दास अपने आप कर सकते हैं तो कर्नल तोमर को बोलो कि ज्वाइन करें। ओके। और प्रिया तिवारी और
Yeah, thank you for live streaming on YouTube.
ओके। There's so many things happening simultaneously that I think Colonel Tomar is trying to get the ethics committee going and somebody else is doing something else, but they'll all join on YouTube if they miss this one.
Yeah, absolutely not a problem. Madam, shall we start the session? It's 4 p.m. now.
Yes, please do ask Jyoti.
Yeah,
Perfectly fine. Yes.
great. Good afternoon, good evening, friends. This is Shrenik from London, the patient ambassador and advocate on Viabo Indian Cancer Society Delhi branch, and a very warm welcome to our Friday speech clinic, the 57th, yes, 57th live webinar today. And I am thrilled to welcome Dr. Jyoti Vajpayee, clinical and medical, a very eminent oncologist from Apollo Hospital, Navi Mumbai, and she got expertise in treating rare cancers, and she has contributed our nation here, I mean India and the other countries as well, and given new life to countless cancer patients and survivors. Dr. Jose, a very warm welcome today, and the stage is all yours. Kindly proceed and enlighten us with your knowledge, experience, and expertise. We are looking forward to listening to you. Thomas, a warm welcome.
Thank
हेलो
you very much.
नमस्कार श्रेनिक जी।
Namaskar. Thank you
Namaskar.
for joining our
Namaskar.
time.
Thank you and good afternoon, everyone. So thank you very much, Mr. Shah and Indian Cancer Society for this honor and privilege. It is definitely, a platform wherein I would definitely like to share my thoughts and experiences so that, masses can be benefited. So delighted to be here. I'm sharing my slides, please. So is my slides visible?
Yes.
Yes.
Great. Right. So today's topic, it is really too close to my heart. And as Mr. Shah already alluded that, although I treat, all solid cancers and many of liquid cancers also like lymphoma and chronic leukemia, with the precision oncology, immuno-oncology, targeted therapy, all kinds of systemic therapy approaches, but rare, ultra rare, complex cases and cancers which demands special care like cancer in young or cancer with comorbid conditions or certain other challenges, they are really close to my heart. So the topic of today's webinar is when cancer defies the rules. So young, rare and complex cancers, especially in the era of precision medicine, how we approach them and what is the way out. And these are my very humble introductions. At present, I'm, working in Apollo Hospitals, Mumbai, and heading the West Zone. Prior to this, I was a part of Tata Memorial Hospitals almost 15 plus years, and it was, really an enriching experience to be part of these institutions. So in this talk tour, we shall be talking about very briefly what is cancer, because I received a couple of messages that it should begin with that kind of thing, and I'm very appreciative of the people who wrote to me. And what is precision oncology actually means: young breast cancer and young other cancers. What is pregnancy associated cancer, which is again a very integral part of these young populations cancers, rare cancers, complex cancers, sexual minority cancer, and what we call as LGBTQ plus population cancers, sarcomas, some more emphasis on AY cancers, and what is our humble contribution to international guidelines and original articles in world over. So cancer essentially is an abnormal, uncontrolled growth of cells with the potential to cause rapid local destruction and spread, that is metastasis. So when no longer cancer cells which are originated from one organ, if they are no longer localized to that one and they spread out, become metastatic, from, for example, from breast, they reach to lung, they reach to liver, brain, etc. So cancer is dangerous because it doesn't really respect boundaries. Now, which lumps may be malignant, or what are the symptoms which really demand an early oncologist referral? So any lump, and majority of the time, like 85% time, it is painless to begin with. And many patients says that I'm sitting on this lump for a year because it was painless. So please understand that majority of the time, these lumps are going to be painless and you should not be neglecting them. Wherever there are rules, there are exceptions. So inflammatory carcinoma, for example, in breast is painful also to begin with. Generally, they are hard, irregular, associated with lymph node swellings as well, skin changes, structural distortion, any bloody discharge. These all could be alarming signs. There can be other symptoms depending upon what organ you are, confined, and they can be persistent cough, fevers, unexplained weight loss, etc. So these are all symptoms one must not be ignoring and taking consultation. Treatment is always a team effort. Surgery alone may not be adequate. Team of medical oncologists, precision oncologists, radiation oncologists, surgeon, nuclear medicine expert, imaging people, pathologists, all together when they brainstorm, there is best chance of planning and best chance of cure. Remember, the first planned treatment is best chance for cure in cancer because it is not really cough and cold. We don't have really time for trial and errors. So therefore, I really request everyone that spread this knowledge all across your family, friends, whosoever you know, that if there is any suspicion or if there is any diagnosed cancer, please come to the centers where there's adequate infrastructure, adequate experts are available, which can plan your treatment really good. What about precision oncology? This is a new kid on the block. I just told you it is a team effort where in surgery, medical precision radiation, oncology, nuclear medicine, etc. But this is now, blessed with precision oncology also. And when we say precision oncology, I mean to say that from histology-driven approach, that means that one size fit all model to one size fit not all model. So for example, previously a breast cancer or lung cancer used to be treated in a similar way, whatever are the finer prints. But later we move to a specific biomarkers. For example, in breast, we say there are either estrogen receptors or HER2 receptor, or either all of them are not present. So depending on that, there are different biomarker driven care which we offer them. And then from there, we further move down and we are doing genomic analysis, we are doing somatic tissue, that means tissue biopsies, we are doing a genetic makeup testing, and then we are finding that what are appropriate targets which can be which are tameable and which are druggable, and where the drugs are available, and whether we can match them appropriately and treat them. Also, similar time, we also try to see whether there are certain abnormalities which make this particular patient more prone to develop toxicity with certain drugs. So when we do all these precision guided care, we call it precision oncology. And not only, there is a high chance that, we may increase efficacy if we are appropriately matching. And there are so many factors which needs to be considered. It is not really very simple. There are chances that there will be more benefit and less side effects. While if we give a blanket treatment to everybody, there are more chances that there might be a benefit, there might be no effect, or there might be only adverse events. So that's where there is a beauty of precision. And also, I would like to emphasize that this precision-directed therapy, although it looks and sounds that it is a really new kid, but actually the story goes back to 100+ years, wherein this gentleman, this is Dr. William Coley, who was a general surgeon, and he actually first experimented of precision or immuno-oncology in a cancer patient who was having a sarcoma, and he injected a bacterial toxin in this patient's blood, and then this by this immune modulation, introducing infection so that there is a immune cascade which comes into picture, and then it actually eradicated the tumor. But it was a very crude method, we all can understand, so it just didn't come into vogue. And for long years there was a dormancy in this field till a couple of years ago, when these two gentlemen, James P. Allison from Texas, MD Anderson, and Dr. Honzo from Japan, they both actually discovered what are the pathway which can leads to immunotherapy in cancer. And this is a path-breaking discovery, I would say. This has actually revolutionized the field, and this discovery should be considered not only one of the greatest in the decades, but in the century, I would say, because with the advent of this kind of immunotherapy, we are having a chance to talk with our patients in deadly cancers, in spread out stage 4 cancers, couple of them. We are having a chance to talk to them for 5-year survival, 10-year survival, even indefinite survival, I would say. So there is a lot which has happened from Kohli's toxin to checkpoint Charlie, especially in many of the common cancers, many of the deadly cancers. But the story is not equal all over, and majority of the time, the lot of emphasis, lot of research, level A evidence is being generated in common cancers. But rare cancers, because the rare cancer, by virtue of being rare, it is very difficult to generate a high quality evidence. High quality randomized trials are rare in these variety of cancers, and that's why these are always lag behind. They are forgotten cancers for long years, and I'm very passionate to treat them. And I feel very important to know is that equally, individually they might be really rare or ultra rare, 0.2%, 0.1% of overall cancer burden. But when we unite them all into one bag, like rare cancers, they constitute almost 20%, which is nonetheless than either breast cancer, lung cancer, head and neck cancer, any cancer which is considered very common. So one must be really careful, and this high time that we should be doing something really good about these cancers to improve the prognosis. Then when I talk about precision, it is definitely molecular profiling, targeted immunotherapy, etc. But it also means that what precise therapies we are offering based on age-specific care, based on gender-specific care. Because for my 40 years young breast cancer patient and my 60 plus years breast cancer patient, there are lot of differences which we must cater, which we must tailor made for to the needs of those patients. Similar time for one cancer, if it is happening in male and female, there might be some metabolism difference, some hormonal difference which may also affect. So there has to be a consciousness about this gender specific care also. Then there are special group like adolescent, young adult, geriatrics, which is like elderly patients more than 60 or 65, depending on which country and culture you belong to. Then some comorbid conditions like patients with diabetes, hypertension, cardiac disease, patients with immunocompromised status, patients on prolonged steroid for anything, COPD, some other conditions, or patient with HIV positivity. Remember, with too much advancement in HIV care, now the patients are surviving really long, and we are seeing a lot of patients who are coming with cancers. So we have to be very cognizant about treating those cancers. Also, similar time, sexual minority cancers or cancers in LGBTQ plus community. Again, there is elephant in the room. We need to recognize it, and we need to appropriately make plan to screen them and to treat them. And similar time, toxicity prediction and appropriate treatment, depending upon what kind of abnormality can affect what kind of drug metabolism. So these all encompasses precision or personalized care, and it is even more important when there are rare or ultra rare subgroup of cancers, because again, level 1 evidence is not there. After 2 or 3 lines, there is practically standard of care doesn't exist, and we need to do a lot of things based on expert guidance, personal experiences, some consensus. So it become even more important. Now I'll move on to young cancer, and among the young cancer, I'll more focus on young breast cancer. I have treated a lot of young breast cancer in my prior institution, Tata Memorial. I'm continuing here in Apollo as well. Breast cancer is really close to my heart, and I always give this analogy. My disclaimer is I'm also a movie buff, and this particular movie, List of a Lifetime, wherein diagnosed with a breast cancer and young woman facing her own mortality. Brenda Lee, who was the lead character, she was diagnosed with a very deadly kind of triple negative breast cancer, and she reunites with the daughter she gave up for adoption as an infant. And this beautiful story, the bucket list came up, and when we see that, oftentimes I see in my clinic also that when a young breast cancer woman or even some other cancer patient in a young age came, there can be many desires, outcome oriented, or how much they will survive, quantity of life, then quality of life as well. There are fertility concerns, pregnancy concerns, there are body image concerns, relationship. There are lots. So I think we need to always balance, and this is also truly precision oncology. This is the international guidelines, BCY guidelines, and they categorically said that uh, treatment determinants are biology, stage, genetic predisposition, patient choice is very, very important, and not age alone. So just by virtue of being young, we should not be over treating them, which is many times, happens, and this needs to be really stopped. And then these guidelines also loud and clearly say that we must be having focused clinical trial for this population, because there are very specific issues, including those of fertility, psychosocial support, genetic counseling, sexual quality of life. Everything is very, very important. This is our own data from Tata Memorial Hospital, and this is a very large series of single center. In Asia and Africa, we see a lot of young patients. Our population as such, it is a bottom heavy pyramid. When we say the population dynamics or epidemiology, we are having more and more young people rather than the old people, and that is one of the reasons. And there are certain other reasons also, but we see more young cancers, and it is almost double than what is it in West. And in our this young breast cancer series, we found that our survival statistics are equal stage match. We are having almost all kind of treatments, and we can really treat them well. But our problem still is that half of our patients come in late stages, locally advanced and advanced stages, and stage is the most important. So stage and biology are the determinants for ultimate outcomes, and they definitely demand an early detection and appropriate treatment. So, but we should encourage everyone to come forward for screening, and I want to congratulate Indian Cancer Society and other many groups that the kind of work it is being done to increase awareness in this regard. And also, after detecting, one must come to appropriate people, appropriate centers where they can be offered a proper plan of treatment. Remember, good start is really half done, and I completely comply with this rule that you all should come well in time, and even if it is late, better late than never, but you should come to appropriate people and appropriate centers so that you can be treated adequately depending upon your stage and biology. Now, very unique situation, pregnancy associated breast cancer. The definition says that, diagnosed during the pregnancy, or 1 year postpartum, or some definitions say even 5 year postpartum. Some are even extending the definitions. So during pregnancy and after that, generally this period is very vulnerable, and there are definitely a different kind of biology. I'm very passionately doing a lot of research in this segment. We have published also our data, and we are trying to safeguard not only mothers' oncologic outcomes or cancer-related outcomes, but also the fetus, or obstetric outcomes as well. So this is our published data in this regard. One of its kind of registry in this part of the world. There are only handful world over, and we initiated this registry, and we found that our survivals were comparable to stage and biology matched people from young breast cancer, when we are very, very specifically treating them trimester dependent. So whether they are diagnosed in first 3 months or 3 to 6 or afterwards, and with a multidisciplinary care of experts, so that as I said, it's a team effort. So not only medical oncologists, surgical oncologists, radiation oncologists, pathologists, everybody put together, and with the obstetric, experts, fetal medicine expert, we are trying to really streamline care in this very niche area, very, very rare, ultra rare, and challenging, complex case. And we have published this data that medical termination of pregnancy does not add to survival, so it should only be done very judiciously, and premature delivery and diagnostic delay needs to be avoided. We can really safeguard maternal and fetal outcomes together. So this must be, circulated widely. Hereditary cancer, very, very important. 5 to 10% of the cancers can run in families, and one must be knowing if there are a couple of people in your family, or even if there are some distant relative. Don't judge yourself. Bring this information to your doctor so that we can really make a family pedigree and try to understand whether this is looking related or not related in now many cancers, including breast, ovarian, uterine cancers, several others. It has become mandatory to test for the genetic predisposition, because the incidence is really more. So that this test is done by blood or saliva, and many commercial labs are doing this now. The cost of testing is also reduced substantially, and there are therapeutic relevance. So if we are finding certain kind of mutations, we can target them with certain drugs. We are practicing this very regularly in breast, ovarian, certain other cancers. And also there is very, very important other role that, this particular patient, if, harboring some mutation, is prone to develop certain other cancers also. And similar time, there is a family cascade also. So this particular patient, if that patient is found to have a, this particular mutation, then family needs to be tested. So all the major, more after 18 years of age, after a proper pre-test counseling, we can subject them to genetic testing. And if we found something, then we can provide them, couple of guidances, so that, we can safeguard them, or we can help them in early detection, or we can even help them in prevention of certain things. So, this is important. Again, this is one of the less common variety, 5 to 10% only, but very, very important and therapeutically relevant. This celebrity everybody know, Angelina Jolie. I really acknowledge her in my talks because she has increased the awareness for this BRCA mutation or inherited cancers substantially, because she was diagnosed with BRCA positive cancers, and her grandmother, she didn't, she was a carrier. Her mother and grandmother were having a cancer. And when she was only diagnosed with carrier and she was not having a cancer, then also she has taken certain measures to prevent it and announce it. So that itself leads to awareness substantially high. And no age is exempt. This is a 10-year-old which was found to have a breast cancer. So people should be aware that, we should not be delaying anything suspicious come into proper, medical help attention. Now, I have talked about pregnancy with cancer. There is another area which is very, very important in young cancers, oncofertility. And when patients are diagnosed with cancer, now we are having really good treatment. So a lot of our patients, if diagnosed in time, are surviving very long. And when the quantity of life is substantially increased, cancer has become a chronic disease kind. We really need to concentrate on every other aspect for quality of life. I'm working on oncofertility and taking this lead in country, and collaborating with many international societies and international groups. And we did this large survey, and we found that the knowledge among the caregivers is also really patchy, lacking, and not people are not really sure. We needs to make our referral pathways to fertility special really strong, and there has to be an affordable oncofertility care, and with insurance support, which is definitely needed. And this is definitely very, very important for this young segment, and we must put emphasis. I believe that Indian Cancer Society can also help us taking this forward. Triple negative breast cancer, another rare variety of cancer, breast cancer, a little aggressive variety. And now, fortunately, we are having a couple of newer drugs, on the armamentarium, which is increasing survival, but it is one of the most aggressive among all the breast cancer subtypes. We have published this largest data from this part of the world in international journal, and we found that again, early detection is the key. We need to spread this awareness, and if we can detect in time, again, we can treat them well. This is our data on supportive care. Again, largely these are breast cancer patients. So this was a randomized trial done from my prior institution, Tata Memorial. And in a small measure, like olanzapine, a lot of you must be knowing this is an antipsychotic pill. And this drug, when we add it in the supportive care of cancer treatment, we can substantially reduce the nausea and vomiting, which happen with cancer chemotherapy, and many people become very aversive to use chemotherapy. And not only it substantially reduce nausea, vomiting, it can, when we use an appropriate dose, that was tested in this particular trial, we can reduce the daytime sleepiness which happen with a higher dose of olanzapine. So this our trial leads to change in NCCN guidelines, which world over is being followed. And this was a podium presentation in one of big breast cancer conference, St. Gallen's, and published in our one of the very lead journal, The Lancet Oncology. So this is our effort from India. These are the endpoints of this particular trial. I'll not go into the details, but it is practice defining implications. And now it is benefiting a lot of patients world over with a very low cost treatment. Again, now AYA cancer. So I'm putting another picture, fault in our stars. Many of you must have seen. So when this AYA segment, which is called as 15 to 39 years of age, there is always a dual challenges which are posed. I have shown you a couple of breast cancer, which are higher side. The breast cancer generally happens after 30, 35 and, goes on. But couple of cancers, they happen, very early. I treat many sarcomas, and bone sarcomas, the peak age is around 15 to 17. So many times I come across a lot of adolescent, and it is very, very challenging. This movie depicts a couple of their challenges very beautifully. So I pose it here. This is our data from Tata Memorial Hospital, wherein the 10-year follow-up data of this particular segment, AYA population, wherein we have shown in bone sarcomas, we can, with our novel protocol, which is osteosarcoma, OGS 12 protocol, and EFT 2001 protocol, we found comparable outcomes, world over comparable outcomes. This is our own protocol. And also we found what could be the challenges with this AYA population. And they beautifully depicted that they need a safe space when they want to talk to their doctor, come out their certain challenges with, with either body image, with either psychological issues, with either school abandonment, with either job abandonment, relationship issues, and so on and so forth. It was very, very, intriguing to know them better while this study was going on. And there's very large data in this rare segment, and it is definitely contributing to the world literature in this regard. A lot of time I came across the body image issue, especially because chemotherapy, which we give for cancer treatment, it is having a side effect in the form of alopecia or hair fall. And that's how I did this randomized trial, first time in the country, wherein we get the scalp cooling machines. And we found that if we are using these scalp cooling machines, it's like a refrigerator, small, in a very nutshell. And then we can find some very good outcomes. We can avoid, hair fall substantially, and that can really enhance their well-being, their quality. And that's very, very important. Now, majority of the centers in the country, they're using this machine. So I'm very happy that we can provide them not only increased life years, but quality to those life years as well. LGBTQ plus cancer, there are a lot of disparities world over, and I have joined the certain experts, including an ESCO diversity force meetings. A couple of my other colleagues from Dana Farber or from UK, when we are trying to find what is the problem magnitude, and with the help of Tata Memorial Hospital, my colleagues there, we're trying to see if we can streamline the care, if we can streamline the screening part of these patients. And we have presented this data in one of the AYA Congress, and we found there's a lot of things which needs to be focused, and we are working in this space. In Apollo, we have kind of started a clinic within our clinic, not separate, wherein we are providing a very dignified care to all these patients, and even the people who are coming forward for their screening. Now, we have talked about that this precision personalized care having several segments. So we have talked about the young cancer, adolescent young adult cancers, LGBTQ plus cancers, the issues of fertility, pregnancy, etc., and pregnancy associated cancers. Now we'll move further to more rare cancer histology specific and otherwise. So when I say rare cancer, they can be either histology wise rare like sarcoma, skin cancers, neuroendocrine cancers, or uncommon presentation of any common cancers. Like for example, breast is a common cancer, but triple negative among them is a rare cancer. Or if I say, there is a very unusual presentation of a common cancer, head and neck cancer, which is only presented with a lymph node, a breast cancer, which is only presented with a occult lymph node, etc. So these all, or if there are some certain comorbid condition, etc., which make the condition challenging. So again, I would show you another picture, the Elephant Man. I believe this Elephant Man was a critical and commercial success with 8 Academy Award nominations. And in this movie, many of you must have seen, I believe, forever imprisoned inside a hideous, deformed body, the unfortunate Victorian Fairground attraction exhibit, Marique, who was milked for every penny by a sadistic showman, Mr. Bites. The ridiculed and multiply disfigured Marie crosses paths with the philanthropic physician Frederick Travis, who really helped him in several ways. And what happened, I will tell you towards the end of my talk. Keep the curiosity on. But I feel this analogy is very, very similar to these rare cancers. So when you have a rare disease or rare cancer, you face two battles. One being the illness itself, and the other living in a world where so few people understand what you are up against. And there is not level one evidence, level one good quality guidelines. So everybody is kind of challenged. There is, there is lack of information. So how to really improve this patient source of information about rare cancer, their treatment option, where to obtain appropriate treatment, everything is a dilemma. And diagnostic part itself, a lot of times the diagnosis keep on going on, and at times with certain misdiagnosis later, once the referral center diagnose it, it becomes quite late. So this all needs to be really worked on. The treatment challenges, there is overall health and social cost to treat these rare cancers are really far high. Off-label medicines problems, reimbursement problems, legal difficulties, and extra bureaucracy for prescribers. These all are hurdles that discourage the development of new medicines in these cancers, and we really need to unite and do something about it. So uh, many efforts are being done to attract industry and to work around orphan drugs, how to make them more feasible. Global collaborations. In this global collaboration, I would like to mention Europe Asia Mission, which is very, very importantly playing a role. I'm part of this Europe Asia mission, and we are trying to, really work on these rare and ultra rare segments. Definitely there is randomized trials are lacking, so there is not a very high quality evidence for rare cancers. So the experts of this Europe Asia mission and otherwise also, everybody is talking and trying to can you convince authorities that there has to be a separate level of evidence. We have succeeded also partly, but a lot of room for improvement. This is one of our published paper, again, Lancet Group, wherein we found epidemiology of rare cancers in India and Southeast countries. And we found that there is very sparse data. This is very, first unmet need, which we need to really work around, so that we should be knowing first that how much rare cancer burden is there in this part of the world. And we are again working in this field. So some of the solutions could be reference networks or center of expertise, and people of these rare and ultra rare cancers definitely needs to come to experts, to people who are having an expertise in these kind of cancers, because these are not a little easy to treat cancers like many and many common cancers, which are everybody's having experience. Hurdles, only few centers exist and funding is not available to cover the increased costs associated with the organizations of these network. And that's why we need to really work in collaboration with national and international bodies to so that these patients can be helped. And again, the societies and NGOs are having a big role. Indian Cancer Society could be one of those. Some of our measures, some of our own solutions based on our randomized data and our other data. So this is our OGS 12 protocol, which is in a very rare kind of sarcoma, osteosarcoma, and we made this protocol, with an interest group and with Tata Memorial colleagues, and we have published it in non-metastatic cancers. We have published in metastatic cancers, and we found that over 2 decades, when we were working with this protocol, we improved the outcome in this rare disease substantially with a fraction of cost and with a easy to administer protocol. And now this is being followed in many, many countries and part of international guidelines also. Some of our additional work in oncology, especially among the international guidelines of high repute or international position papers. So I want to just name a few wherein we could become the country's voice. So this is the advanced breast cancer guidelines, and these give guidance to with regard to advanced or metastatic breast cancer world over. And very humbled to represent country and continent for success of 3 times in these guidelines. And for this is the Society of Immunotherapy of Cancer guidelines for gynecology. And again, become the voice for treating how to treat best with these novel treatments, immunotherapy in these segments. This is a bone sarcoma, ESMO Eurocan, the European guidelines. And again, I could represent the country here to provide the care in these kind of rare cancers, how to define care pattern. And this is the soft tissue and visceral sarcoma guidelines, ESMO Eurocan. And again, with a handful of experts, we could provide directions to many people who are treating these rare cancers, and it becomes challenging for them. This is some of the position papers like in epithelioid hemangioendothelioma, which is an ultra rare cancer. So this consensus paper from a community of experts world over is very, very vital in this regard. And again, there are certain efforts in gynecology space, young cancer space, which we are doing to help, world. This is our own immuno-oncology data. This is from our Immuno-Oncology Society of India, which is the only legal and national society in India for immuno-oncology aspects. And here in the initial part, when immunotherapy were very, very costly, now they are fortunately the cost is cut down, but still it is challenging for many people. And here we found our own solutions that even if we are using a short course, then also we can found comparable outcomes with the caveat of being partly retrospective and prospective. This is one of our solution. This is our data in in this with the short course, median number of 5. It's published in UICC's official journal. And this is our melanoma data. Again, melanoma is very rare in this part of the world, unlike the West and tropical regions. And we found that even though if the novel treatment cannot be given, still with the systemic therapy, we can do something. This is a very interesting, very rare case, which is published in British Medical Journal. And this is a professional dancer and very young. So it was young as well as rare. So I'm presenting it here. And she was having a melanotic schwannoma with a Carney complex, and very rare third recurrence. She came paraspinal disease, so very delicate location, and it is an unknown territory. Practically nothing is known, and all patients almost succumb to their illnesses. So first time in the history, I used immunotherapy for this particular disease along with radiation, and we were collaborating with Sloan Kettering Center also, where I had my own immuno-oncology training, and we found that we could really treat this lady well, and she enjoyed a good quality years with immunotherapy. And this is the first evidence that this therapy work in this particular rare cancer. This is our Ewing sarcoma, another rare cancer, experience. And this particular protocol devised in Tata Memorial worked really well in this scenario. So this is our another novel protocol, metronomic therapy, with along with Dr. Banavali, who is my mentor and long-term collaborator. We've devised this protocol, and in desmoid fibromatosis, this very cost-effective therapy, $130 in a year, in comparative to several lakh dollars of other very expensive therapies. We found good survival and good quality of life. So these are our own solutions to world. These are certain prognostic markers which I devised during my AIMS, All India Institute of Medical Sciences, Delhi training. and yeah, along with my colleagues in AIMS, and we found that VEGF expression, MRI parameters, PET-CT parameters, they all could predict osteosarcoma prognosis in a good manner. And also from Tata Memorial, we again find that compliance to treatment, that means adherence to treatment, which is very, very important. And this is again an independent prognostic marker. So, with all these data in rare cancers like sarcoma, we were asked to provide, a write-up to, how should the low middle income countries practice care for these, patients. And this, article published in Pediatric Blood and Cancer is providing, a guideline for, and helping patients. So we are very humbled about it. This is epidemiology of rare cancer in India and South Asian countries. And again, as I said, we need to really, really work on these forgotten cancers, and right from the scratch till late, we are trying to build, a lot. Also, I'm part of Lancet Commission for Adolescent and Young Adult Cancer, wherein we are trying to amalgamate the evidence from all across, and we are finding it's very challenging, very difficult, because this adolescent and young adult is a really neglected segment for large years, and we are trying to make models of care, that how can we enhance and how can we improve care pattern. So I'm very thankful to Lancet Commission and my colleagues who are working from all over the globe in this regard. So what is the way forward? We have to have focused clinics, which I'm now started. I've now started in Apollo, and like adolescent young adult clinic for this special segment of 15 to 39 years of age. Then geriatric clinic, which is 60 or 65 years plus, with certain other challenges of mobility, comorbid conditions, polypill therapies. Then rare care clinic, which is helping with rare cancers and ultra rare LGBTQ plus cancers, which is helping this particular challenged entity. Oncofertility pregnancy practices across. So true precision directed treatment, which we are offering. And I think this is the way forward in oncology. But again, please understand, there are a lot of progress. There is a lot of good drugs, precision oncology drugs, but nothing is panacea. And we must be very, very concerned and vigilant about toxicity of systemic therapy. There can be many side effects. Practically every organ system can be affected. So must be delivered under expert hands, must be delivered in the centers where infrastructure is available. So I have shown this picture about the elephant man, the rare, ultra rare, complex cancer segment, and I am towards end again, showing this. So there, there was a very sad end, because that Murray, undergoing lots of ups and downs, finally succumbed to his illness. And you know this there was a sad end, and after the movie everybody feels, and could there be a better end of this movie? And similarly, I always feel, could there be a better fate of these rare and ultra rare cancers, and how to move forward in this space? And I think these focused clinics with focused group of experts and with collaboration all across. And when I say collaboration, it is not only among the doctors, it is, you need an entire village to really cater these rare cancers and complex cancers in all these challenging scenarios. So, NGOs, social workers, family, friends, every responsible person in the society is having a role. Media, so everybody put together, I think we can make a difference. So this is a very good side, wherein the French toast is not French. Similarly, white chocolate is not really chocolate. Guinea pigs are not really pigs, and Danish pastries are not really Danish. And similarly, rare diseases are not rare, because put together they constitute 20%, and that's what about the rare cancers, and that's why we have to cater them really well. We have to give them equal importance as the common cancers. With this, I will towards the end. We are having a unique population in India and SAARC region. We are having unique challenges, so we have to have our own measures, our own solutions, as I showed in few of my published work with my colleagues, that we can really propose our own solutions to world. And precision era, wherein one size does not fit all model, is really, really, increasing hope, and especially these challenging scenarios. Our problem, our solutions. We need to have resource appropriate care. which can be sustained. And when I say precision, I feel economics is also science. And when I say precision, we have to also understand the logistics challenges, and that also should be considered while we are making a precision medicine plan. There has to be dedicated clinics. We cannot compare and treat apples and oranges together. So precision therapy is a way forward. Community education, avoid inadvertent treatment, early referral to reference centers and appropriate oncologists, very, very important. And national, continental, and international collaborative efforts from all across is really warranted. These focus clinics and everybody sensitive and sensitized towards providing a precision directed authentic care is the way forward. So with this I will end. And prevention is always better than cure, because it avoids the labor of being sick. And precision therapy is extremely important, because we need to customize the product to our customers. So with this I will end, and thank you for listening to my thoughts.
Thank you, Dr. Jyoti. One of the biggest takeaway for today's session is rare cancer is not rare to treat, and that is the best takeaway for everyone. Now, Dr. Jyoti, let me give some of my observation. Like you said, I mean, we are not celebrities like Angelina Jolie, right? But yes, we at Indian Cancer Society, we are committed, being innovative. Until now, we have invited organ-specific oncologists, to share their knowledge, experience, expertise. But today we have invited you, especially to talk about rare cancer, and we want to emphasize to the people whoever is listening now and who will be listening later on, that there is absolutely a beautiful life to lead when you are diagnosed with the rare cancer. So we wanted to talk about cancer awareness, prevention, and last but never the least, HOPE. That means there is definitely a life, that is definitely life even after you get diagnosed with the rare cancer. One more thing, why we are doing this, the knowledge, experience, expertise, and everything you have shared, believe me, this cannot be made available to a common man at all during a private consultation, because you have your own priorities. So this is going to make a huge difference. And thank you very much for giving us and full of information in last 40 to 43 minutes. I have said enough, and let me open the room for the question. Jyotsna madam, if you would like to ask, or Priya Parmar.
Well, if I might start, uh, we've been doing a lot of work in supporting the patients in various hospitals. At least I started off way back in the last century. And so when you were speaking, some of those faces came back to my memory. I did not realize that breast cancer during pregnancy is so rare. But I remember this young woman. It was winter in Delhi. She was always wrapped up in a shawl. And one day she opened her shawl for something or the other, and we realized that she was quite hugely pregnant. So we spoke to the oncologist there, and he sent her to the gynae department and said, go and meet the doctor. Well, she came back on the next Thursday. These were all Thursday clinics. And she shoved something in my arms like a little portly. And when I opened it, it was her baby. So you realize how far gone the pregnancy was. A perfect little baby, no damage at all. So that was one thing that came back. The other was about the LGBTQ community. I know that they have got their clinics where they go to collect their medicine for the next month. And that is where the preventive care section kicks in. Our volunteers in certain branches go in and they actually do a screening for them while they're waiting. So I'm just wondering, Jyoti, is that an opportunity that you can also use? That you take your clinic to their clinics?
I think
Because if
wonderful. So definitely, yeah, yeah, ma'am. Please complete. Then I'll tell you.
no, I said, it's a case of the mountain coming to Muhammad if Muhammad doesn't come to the mountain.
Sir, so well said, and so I'm really humble. So, ma'am, basically, the thing is that yes, we need to work both ways because we have opened this clinic, but again, I'm connected with and from Dana Farber, Dr. Shell Mangi, or from UK, Dr. Alison Mayburner. Couple of times, I'm getting information referrals from them also, but here still there is a lot of stigma. So many times people privately wrote to me, but they don't want to come in front and open. So that's where the challenges rise. So if in those clinics they are more comfortable and somebody is identified, I think then they can come to us and we can take care.
Anyone who comes to their clinics is already a certified LGBTQ.
Right.
So if you go there and check them out, I think you'll be doing a real service rather than waiting for them to come to you.
We can try on that as well. We can plan a schedule, and if there are couple of patients together, then definitely that can also work out. So I think we again needs to collaborate and make a proper plan in
Yes,
this regard. I would be very
yes,
very happy and keen to, because we need to be having diversity and inclusions, and this segment really need care.
yes. But thank you very much. This was one of the best of the webinars that Shrenik has organized. Perhaps for the lay person, I don't call them the masses, just the lay person. We will call you again to do a much more simple version of the same thing. And for you to talk not about research papers or not about any of the wonderful work you're doing, which is of interest to us, but may not be to them. Maybe you will talk to them about the same thing, and particularly about this community so that we can take the YouTube section and pass it around their community.
Absolutely, would love to do that.
Thank you.
Dr. Bajpai, do you think clinical trials are often the best hope for patients with rare cancers?
Yes, absolutely. I think this is a wonderful, question and comment, and I said yes because, as I said, by virtue of being rare, the level A evidence or high quality guidelines are not really available majority of the times. So, if there is a possibility of clinical trials, then I always encourage them. Maybe if they are first time, getting treatment, then if there is a standard of care available, they should be offered that. But after that, I'm very very open to have anything which can make their life better. We have just witnessed in the recent ESCO meeting, wherein for long years a pancreatic cancer, which is deadly cancer, and we found now the KRAS, the RAS mutation is being kind of taken care by the decades of work and the targeted therapy, which is making a real difference in their lives. Similarly, in chondrosarcoma, which is another very rare cancer, there are drugs, targeted therapy, which are coming after long delay. So certainly I would encourage people to participating.
So, when you had also mentioned that 20% are rare cancers, it doesn't work down to it being so rare. So, how do you all make treatment decisions when clinical guidelines are limited?
Right. So I said that, individually they constitute 0.2%, 0.1%, 1%. So they are definitely rare or either ultra rare. But put together, all these rare and ultra rare, they
Yeah.
constitute as much as 20%. So, lot many times when the level one evidence or high quality guidelines or high quality randomized evidence is not existing, we have to rely on experts, opinions. And that's where, opinions among the group who is having the largest experience of treating them, or those position papers, those consensus papers, which are made by these experts, and personal experience of your treatment or your other international colleagues, who are treating in these niche area, become very, very vital.
That's right. Yes. Yeah.
That demands the highest precision, I believe, to treat these rare cancers. And every other case is having another challenge and different than the previous one.
Anyone else?
Is Aruna Umat there?
Yeah. Can I ask a question, please?
Absolutely.
Yeah.
You're most welcome.
Yeah. Thank you, Dr. Jyoti. I really enjoyed your thing. It was full of lots of research, a lot of clinical data, and the success stories with immunotherapy. I really enjoyed, and I think that really gives a boost to immunotherapy. The question I wanted to ask is one is, one of the rare cancers and which is neglected as such, neglected also by government, and that is skin cancer in India. In countries like Australia, it's very prominent, so it's given. In India, I find that a lot of importance is given to these cosmetics. That is, you use sunscreens with a high SPF factor and so on. But you don't find the percentage of people with skin cancer or people coming forward. They think they're treated with all sorts of things. What is your take on that, please?
So I think very important question and very important observation. So I would say that, in this part of the world, melanoma, which is the most common skin cancers, and as you rightly mentioned, Australia and other those parts, it is quite prevalent while it is considered rare in this part of the world. I published the largest data of melanoma from my prior institution. And when we were studying that bit, we found that many times, the referral is not happening. I established the Melanoma Center for Excellence, and that's how started getting referral from all over. But still, the registry, melanoma registry, is not a kind of existing. We don't know our true incidence and prevalence. And
Right.
previously in China, this was the case. But for millions and billions of population, even 0.1% constitute a lot. So I feel if we streamline, if we try to capture our incidence and prevalence properly, if we strengthen these registries, we can get many more. A lot of times, they are misdiagnosed, they are sent back because still people are not much aware. At times, they also feel that these are not treatable conditions. While melanoma is one of the disease in my limited lifespan, it is revolutionized. So while I was the resident, it used to be a death sentence. And now with the advent of immunotherapy, it has become like locally advanced breast cancer. So we are seeing many, many cases, those initial immunotherapy trial patients who are surviving 15 years. And that is the beauty of immunotherapy and even the targeted therapy. So I think this message should go a long way that, we need to detect in time, we need to send to proper people, and there is a very good treatment which is available. Incidentally, in this 25th July, from Society of Immunotherapy of Cancer, my colleague and collaborator, Dr. Ahmed Tehrani, who's a very big, melanoma specialist. He's traveling to India, and we are doing a big, in-person meeting, and then later a webinar also. I would reach out to you guys so that can be spread. And, we want to create this awareness among dermatologists, among, other general surgeons, because a lot of time we see a mucosal melanoma. We see gynecological, anal, rectal melanomas, even ophthalmological. So our mucosal and cutaneous melanomas are similar. So we are again catering a different disease, but I believe if we streamline, our prevalence will be more.
I did notice in one of your publications that you would mention about melanocytic and schwannoma. What is that? Schwannoma is in the Schwann cells are in the myelin. So what is that? What exactly
Right.
was that?
Yeah, so that was initially. So basically, I saw that case in third recurrence. So initially, she began with a schwannoma paraspinal region. She was operated and she was followed up. She recurred every time while she was recurring. The pathology is also find the virulence is increased, and she was the recurrence interval also decreased. When I saw her in third recurrence, by that time it was couple of additional nodules, etc., and they are typically melanotic. So, in each recurrences, this melanin pigment is also increasing. And then we
Oh,
thought that perhaps this melanotic schwannoma, and with each recurrence, which is showing more aggressiveness, this should be this should behave like melanoma. And first time we tried, because melanoma is a poster child for immunotherapy, and it worked really well. So that patient could survive long years and with good quality of life.
yeah. Thank you so much.
Thank you very much for very, very relevant questions.
As a follow-up,
Anyone
tell
else?
what is the treatment for skin cancer? How is skin cancer treated?
So if I'll give an example of melanoma, now there is a wonderful, track record of treating with immunotherapy. They are
Uh,
one of the most immunogenic tumors. So immune therapy with PDL1 or CTLA4 is working very good. Then there is a BRAF mutation. So we are treating with targeted therapies also. And single agent immuno, then double agent immuno, then this. And also even in early stages, we are combining with neoadjuvant immunotherapy, later on surgery, etc. So the armamentarium is really widened. For other skin cancer, case by case, there are a couple of other diseases like Merkel cell. There also immunotherapy role has come up.
I'm going to read all your papers, Dr. Jyoti. They seem very
I would
interesting.
like to sit with you on a coffee. Would love to.
Yeah, do that.
Uh, Anyone else? We are close to the end of today's session. First of all, Dr. Jyoti, thank you very much for joining us today to talk about the rare cancer. And believe me, today for me at Indian Cancer Society is a very big day because something big has come up in my life, and with the kind permission of Jyotna Madam, I would like to ask Sneha to play that small clip of 3 minutes and 24 seconds. Thank you.
Give me a minute.
Thank you, sir.
Sanchita. My
Sapna,
session
Sapna,
with
I mean,
Shrenik is
we are
just
about to wrap up.
ending, so I'll
You
join
can
after
ask
that.
last question to Dr. Jyoti, and then we'll start wrapping up the today's session.
Sorry, I missed that, Shrenik. What did you say?
You know, Sapna saying she wanted to ask one question, so I mean, I would like Sapna to unmute and she can ask the question, and then we will wrap up the today's session. And
I,
thank
I
you very
think
much.
I think you need to wind up this session. Sapna can put it in the chat box and we
I
will
put
forward.
it in the chat box to
Great.
ma'am.
That's very nice, Sapna. So if you don't
I
mind,
asked directly to the ma'am.
yeah.
Dr.
All right. Thank you.
So thank you very much,
Thank
everyone, and Dr. Jyoti. So thank you so much for giving us, I mean, enormous and thought-provoking talk. I mean, it's all about treating rare cancer is really not rare, and this can give a lot HOPE to the countless individuals throughout the world. Thank you once again,
Thank you
and
very
thank
much.
you.
And I put my phone number, so if there is anything anybody want to personally,
You're going to get flooded, but thank you.
thank you very much.
Thank you everyone. Thank you for
Thank
joining.
you. Thank you, ma'am. Thank you,
Thank
everyone.
you. Bye bye.
So
Bye.
really